Okay, good. So we are waiting just for a few minutes, and this will all be with the moderators. How are you going to do this, Nikolay? What is your plan? Is Joachim here and Atul?
So I think we asked Jibran to start his presentation. And then somewhere midway presentation, as he's speaking about different techniques and different things, I'm going to show you a case that we have done recently with some considerations about biomechanics, about safety and all that. Just there's going to be a short presentation of a case and the way of thinking. And then I think Joachim said that because my case is posterior C1 fixation, and Joachim said that he wants to present anterior C1, C2 fixation. So we're going to let him present this as well. And then we continue. And after this, we have Professor Atul Goel presenting. And after that, we have Joachim again presenting, and then after that, we're going to finish with the amazing models that Victor Hugo will present to us. I think this is a good plan. Someone, you're muted.
Imad, can you unmute Joachim, and maybe you can make him a co-host, and I just leave me out there.
Oh, it works. Great.
Hello, Joachim. We were missing your laugh.
Hello, Joachim.
Hi.
We were discussing how bad Germany has not sorted its COVID out, and how bad the doctors have not treated patients well.
Hard to say. Well, they are crying a lot, but I think it's okay.
Yeah,
it's joking. Not very bad.
We were not discussing that. We were just
Salman,
joking.
if you're talking about like that to Joachim, you're risking to end up on that shelf like this animal at the back.
No, it's fine. I don't think it's a problem.
And it's getting better?
Yeah, it's getting better. It's not really bad.
Okay, so it's Nikolay and Ruli, it's all yours.
Okay, right. Okay, shall I start, Ruli? Ruli is smiling.
Let's start it.
Okay.
Sorry, I forgot to unmute.
So it's a pleasure to start today a new project under the World Spinal Column Society. This is spinal neuroanatomy.
I'm sorry. WFNS Spine Committee is a part of it as well. So there is WFNS Spine Committee and World Spinal Column Society together.
Thank you so much for the correction. So this is a new project that we are starting, the spinal neuroanatomy series. And the first one that we have chosen is C1, C2, CV junction, basically. And we have presenters today that we should not introduce them so much, because speaking about CV junction and their names, this all goes together naturally. We have Jibran today presenting to us some consideration on basic anatomy and different techniques. And so I would like to start now with Jibran. Jibran, please. Jibran is a fellow, spinal fellow in Liaquat National Hospital in Karachi, Pakistan.
Thank you for introducing me. I hope everyone's doing well. Can everyone hear me properly?
Yeah, we can hear you.
Okay, I'm going to share my screen now. Okay, so we will be talking about the occipital cervical junction today. with specific regards to the neuroanatomy and certain approaches for fixation. I'm going to give a slight introduction, then we're going to talk about osseous structures, their associated fracture patterns, fixation techniques that can be used, as well as the other associated structures such as ligaments, neurovascular, muscles, and then I'll talk a bit about biomechanics. So as you all know, the cervical spine consists of two morphologically different zones. The first is the occipito-cervical junction, where it consists of the occiput that attaches to C1 and C2. Here, the main movement that occurs is rotation and nutation, as well as some flexion and extension. However, the majority of flexion, extension, and lateral bending occurs at the subaxial spine. As I said, the occipito-cervical junction is composed of the occipito-atlantal segment and the atlantoaxial segment. This is the most mobile spinal segment, where 60% of the cervical spine rotation occurs and up to 40% of flexion and extension can occur. There are unique biomechanics at each component segment, as you can see in the bottom left corner. The occipital condyle attaches to the C1 lateral mass, which then connects to the C2 lateral mass and then the C3 lateral mass. So I'm going to start from the bottom and then move progressively upwards, talking about C2 first. The body occupies a central portion, and this forms the anterior limit of the spinal canal. There are various attachments of ligaments and muscles on both the anterior and posterior surface of the vertebral body. And the AP diameter in females on average is about 15, and in males is about 20 millimeters. The dens is a structure that projects superiorly from the body of C2. It is originally derived from the body of C1 that disconnects during development and then fuses with the C2 body. The total height at this level is up to 40 millimeters with a diameter of up to 10 millimeters. And the main motion that occurs at this joint is rotation. Translation is usually restricted by the ligamentous complex associated with the dens. The dens tip has attachments for apical ligaments centrally. It is flanked by two alar ligaments laterally. The transverse atlanto ligament traverses the posterior border of the dens to keep it in place, and the neck narrows to where it meets the C2 body. Here are certain fracture patterns of C2. And as we can see that type 1, type 2, type 3 have different treatments. Type 2 is further divided by Grauer into 3 types, where we have a transverse fracture line at the waist, or we can have an oblique fracture line that goes from superior to inferior posteriorly. And then we can have another oblique fracture line that goes from inferior to superior posteriorly. Different methods are used to fix these different fracture patterns, where type A usually requires only immobilization, type B requires odontoid screw, and in type C, odontoid screw is contraindicated because during fixation, this fracture fragment can move and cause neurological injury during surgery. So we'll talk about the odontoid screw. Usually it requires an anterior approach. We reach the C2, C3 disc space through an anterolateral retropharyngeal approach. A partial discectomy is done and the C3 end plate is drilled to make some space for the screw. And then the screw is directed towards the odontoid fracture segment. As you can see, the arrow here sort of tells us what direction the screw will go in. This is an anterior view of the CB junction. You can have single screw versus a 2-screw technique. The 2-screw technique was introduced because people thought that it might lead to more stability in rotation. However, studies have found both of them to be biomechanically equivalent. The major contraindications to C2 odontoid screw is type 2C Gower fracture pattern, and if there is a transverse atlantal rupture or if the fracture is more than 6 weeks old. We can also perform an odontoidectomy as an alternative and then attach a C1, C2 plate. And alternatively, we can also do a ventral atlantoaxial facet screw fixation. The screw fixation is denoted by, the direction is denoted by the red arrows bilaterally. We can have certain variations with the C2 dens. The most important one is the presence of an os odontoideum. There are 3 types. First is orthotopic, where the the os is in the normal position. However, there's a wide gap between the C2 and os. In this topic, we have a displaced fragment that is usually attached to the clivus. And then we have an os terminal, which is a very small fragment right at the tip of the dens. This os can be usually confused with fractures of the dens. However, it is usually half the normal size of the dens, and it is associated with a hypertrophied anterior C1 arch. It is caused, there are two theories as to why it is caused. First is the failure of the dense ossification center. And secondly, you may have a fracture in the dense growth plate before the age of 5. Here are radiological pictures of the different types. On the left, we have orthotopic. This fragment moves with the dense body in atlas and does not usually cause instability. With the dystopic, it is usually fused to the clivus, and neurologic compromise can occur in flexion because of odontoid impingement onto the cervical cord. And the os terminal on the extreme right can be confused with a fracture. So here is the first case. We have a 65-year-old male with a history of fall and neurologic compromise present on examination. I would like to ask the chat if they could share their opinion on what type of fracture it is and treatment. And I would also like the moderators to share their cases of the anterior approach. I'm going to stop sharing my screen.
Okay, so Joachim, I think you said you have anterior approach. Do you want to continue?
What good? No. I just I don't think best is now we keep on the schedule, but I think now we discuss the case, isn't it?
Yeah, we can discuss the case. I have a posterior approach case to present. So I can, maybe Joachim, you can say a few words about this case presented, and then I will show a case after that.
Okay, just show us the images again. I think it's a very good case.
Jibran,
can you show us the radiology images?
Thank you.
Just the last image. So there's a frequent discussion. What is Anderson Alonso type 2 and 3? I mean, this is when you look at the books and consider this the radiological image is type 3 because it involves the body of the dens. But I rather like the thinking about type 2 is the type I can still approach from anterior with an odontoid screw. Well, this. If we consider there are no other injuries, then this is still doable with an odontoid screw, but it's a high risk that you have a pseudarthrosis. The first issue I see is that there is not, I think there's some bone already missing. It's a compression fracture a little bit because it looks very small, very, very short to me, this part. Then the other part is it's the angulation. It's not a flat fracture. It's an angulated fracture. So this is always very difficult to really address with an odontoid screw. So probably I would discuss with the patient, and then if the patient wants to try, we would do an odontoid screw. But I think there's a high risk that you come back in 4 weeks or 6 weeks with a posterior approach in this case. That would be my personal opinion. If I had it myself, and I know there's somebody who is very experienced, maybe you could try from India. But Joachim, I think it's basically a posterior approach.
Yeah, Joachim, I would agree with you, especially after you say that. I know that in your practice, you have a big number of anterior odontoid fixations. Here in Belfast, we do this, but not this often. So I think for me, this will be also posterior approach C1, C2. What do you think, Salman?
I think I totally agree. You know, doing this anteriorly may not be the best option. You know, you can talk to the patient, but I think generally speaking, if you've got a gap like that, you'd be better off going from posterior.
Can I make a comment, Salman, you think?
Yes, Professor Goel.
See, for me, you know, I know Joachim likes odontoid screws and all, but for a long time, I have completely abandoned anterior surgery for craniovertebral junction stabilization. All kinds of anterior surgery I have completely abandoned. More because I'm more experienced in C1, C2 from back, that is one thing. But I find that posterior fixation is not only strong biomechanically, it is absolutely wonderful to do from behind. You to do solid screw fixation in the atlas. My issue is when there is a fracture of this kind, the atlantoaxial joint is completely unstable. You cannot preserve the atlantoaxial joint in such a situation. That is what is the argument. Like if you do odontoid screw, you can preserve the atlantoaxial movements. That is the, but you see the facets here completely disrupted, and there is no question of preserving the atlantoaxial joint. So my answer to this question is atlantoaxial fixation in all cases from behind.
That's
Well,
definitely.
of course, I have to disagree on this.
Okay.
Actually, you have more images. I don't think that they're really, the C1, C2 facets are not in shape. I think this is a little bit too far. It's not really the level of the facet joint. The coronal section is not representative for the facet joints.
But Joachim, even in the beginning, you
the
said
midline.
that you're gonna do this case posteriorly. Are you now changing that?
No, I think it's very likely that when you do this from anterior that you have pseudotrails and you end up with a posterior. It's very likely. But there are some cases we did actually, and you're surprising how nicely this goes. And I think there's no doubt, in my opinion, that even if you do C1, C2 from posterior and remove the screws after 1 year, there's a very high fusion rate. Fusion rate means that also the joint is fused. I mean, the disability is much higher. Sorry to say this, Atul, but if you have a nice odontoid screw, it's really, these patients have no long-term problems.
Joachim, do you think that the facet here will be functional after this fracture and after what we see on these
I don't know the images. It's probably not, but I don't know the images.
Okay, good.
We have to, I mean, you see that this is not in the coronal section, just only show us the C1. There's no C2 lateral mass, no C3 lateral mass. It's not the right level. So if we get more images, we can discuss, but I don't think that we have.
I'm sorry, I don't have any more images.
So let's move on. Yeah, let's move on.
The next slide.
Okay, so what shall I present also another case of C1, C2?
You want to present once we moved a little bit forward?
Okay, yeah, that's okay.
Yeah, okay, good.
So moving on to the pedicles of C2. These exist medial to the pars. You can see the green outline, and the axial cross-section is where the pedicles exist. The blue outline is where the lateral mass exists. And the green arrow shows the direction of the pedicle screws we place in C2. And you can appreciate how close it can get to the vertebral artery. The foramen transversarium exists lateral to the C2 pedicle. It is usually angulated 45 degrees lateral, and it is roofed partially by the superior articular process of C2. The posterior spinous process exists posteriorly to the lamina. It is usually very large and bifid because it has extensive muscular attachments. However, it is one of the landmarks for posterior approaches. When we're inserting a C2 pedicle screw, we need a posterior exposure. Pedicle screws are usually very biomechanically strong. However, there is a risk of vertebral artery injury. The entry point is just at the lateral edge of the superior margin of the lamina. The direction can be up to 25 degrees medial and 30 degrees superior. Here I have another picture where the entry point is slightly modified. It's in the midpoint of the pars, and thus the angles are also different, more medially up to 45 and more cephalid up to 45 degrees. So my point here is that depending on the insertion or entry point of the screw, the angles need to be changed or variated slightly. Here we have a radiological image of C2 pedicle screws. As you can see, they're passing through the pedicles in the axial section and in the coronal section. And to the right, we have an X-ray image of C1, C2 pedicle screws and C1 lateral mass screws. Okay, the superior articular process, it rests on top of the pedicles and it forms shoulders superiorly to attach to C1 facet joints. It has a concave surface, and the inferior articular process, the orientation is a bit different. It's more similar to the subaxial spine, and it has a convex surface. In between these two processes, we have the pars interarticularis as outlined by the blue line. It is laterally bounded by the transverse process. And in hyperextension, this is the area that usually fractures because of the offset coronal orientation of the facets and the disproportional length of the pars. Here is an axial view again showing the pars in the blue outline and also the trajectory of C2 pars screws that can travel very close to the vertebral artery. This is an anterior view of the CV junction again. Here I just want to emphasize the direction of forces that travel along the CV junction as represented by the green arrows. So the upper arrows are angulated slightly in relation to the coronal plane, and then the forces travel posteriorly along the facet joints. The force is also divided anteriorly to the C2, C3 anterior components, such as the C2, C3 disc space. And because of this orientation and direction of forces, usually it leads to a fracture of the pars. So this is the Levine-Edwards classification of pars fractures. Type A is usually associated with the displacement of less than 3 millimeters. Type 2 involves disruption of the disc space with angulation or displacement. And in type 3, we have an additional C2, C3 facet disruption. All these different types usually have different treatment options, with the more unstable ones usually requiring operative stabilization. So the C2 pars or lateral mass screw can be placed if the pedicles of the C2 have an unfavorable anatomy. The entry point is roughly 3 millimeters superior and laterally to the medial border of C2, C3 facet as shown by the blue dots. This entry point is inferior to the entry point of pedicle screws. And in contrast, we have a direction that is up to 10 degrees medial and can be up to 40 degrees superiorly. Here, the screw length is between 12 to 18 millimeters. This is a diagrammatic representation of the pars screw, where the entry point is just above the C2, C3 facet joint. And in the middle, we can see a straight trajectory of the C2 pars screw as in contrast to a medial trajectory, a much more medial trajectory of the pedicle screw. We can also place a transarticular C1, C2 screw. However, this has the highest risk of vertebral artery and nerve injury. This type of screw completely obliterates rotation because it crosses into the C1 lateral mass from the C2 facet. The entry point is similar to a C2 pars screw, and the direction is usually the same 15 degrees medial. However, it is a bit more angled, a bit more superiorly, up to 50 degrees. The screw length is also much longer and screws can be placed up to 43 millimeters long. Here we have post-op X-rays of C2, C3 transfacet, C1, C2 transfacet screw, and the red oval shapes denote the position of the vertebral artery on both the images on the left and on the right. And as you can see, it crosses very close to the vertebral artery. The laminae of C2 are angled posterior-medially and go inferiorly from the lateral mass. This is the largest lamina of the cervical spine because it is involved in transmission of a lot of forces from superior to inferior. The length can be up to 35 millimeters, whereas the thickness can be up to 7 millimeters. Translaminar screws can be placed within these lamina. The entry point is the junction of the lamina and the posterior spinous process, as we can see over here. The red arrow shows the direction of the laminar screw. Screw length can be up to 30 millimeters of length. Some studies suggest that this screw is a bit more biomechanically inferior to the other screws. However, it poses the least amount of risk of damaging the vertebral artery. Here's my second case. A 34-year-old male with history of a motor vehicle accident. He has neurological deficit present on examination. if the moderators would care to discuss this case.
Nikolay?
Okay, so shall I present at that point my case as well, and then we discuss different considerations?
Okay, yes, let's do that.
And start sharing screen.
So let me share my screen now, guys. Okay. Okay. Right, so I'm going to present a short case and a few slides on different considerations with regards of different treatment options. This is the case that I would like to present to you. The first reason why you need to fix C1, C2, of course, is trauma. Most of your cases will be that, but the second the second most common reason would be degenerative changes. I'm sure later on when Atul speaks, he will tell us many other reasons for this, but I will continue now with the case. So this is a 40-year-old female that we have operated just a couple of weeks ago with the signs of progressive myelopathy. Increased spasticity, balance problems, frequent falls, pathological reflexes present. You can see top left corner MRI scan that shows compression of the spinal cord at the level of C1. You can see the posterior arch of C1 compressing the cord. Obviously, this is in a neutral position. If you consider the right side of the screen, the right top, you can see on the dynamic X-rays significant movement at C1, C2 segment. And I've measured for you the left bottom X-ray. You can see that the ADD is over 10 millimeters. So this was a case that we decided that we definitely have to fuse, and we were considering different options. These are the options that you may consider when you would like to fix C1, C2. You can consider transarticular screws, you can consider pars, C2 pedicles, C2 laminar. All these have been described so far. The considerations for you would be you have to think about the biomechanical stability, and then you have to think obviously about the safety. These are the first two considerations that you should have. I have found a nice paper that is comparing the biomechanical stability of the different options. You can see that the transarticular screws are one of the options with the highest biomechanical stability. Also, we have to consider the safety, and the safety is related with the vertebral artery. This is the diagram of the course of the vertebral artery. You can see that about 45% left dominant, 30% right dominant, and codominant in 25%. You have to consider also anatomical variations. The majority of the anatomical variations are below C2, but you still have to think that there might be variations at C1, C2, and you have to think about them. So, interesting article which I have found on the complications of the C1, C2 surgery and spinal surgery in the cervical region with respect of vertebral artery injury. This is an article which is published following research done in the Cervical Spine Research Society. 141 members participated, and they have isolated 111 vertebral arteries out of 163,324 cases. And so as you can see that the majority of the vertebral artery problems are in the posterior instrumentation of the upper cervical spine. But you can see that there is a significant portion anterior corpectomy and so on and so on. But this is not the scope of our talk today. So if we have to discuss the safety of different options, this is a nice diagram showing you that the transarticular, as mentioned already, is the riskiest option. Then followed by PARS, C2 pedicle, and C2 laminar. These are the main options that you may consider in C1, C2. This is what we have done. We have decided to go for transarticular screws at C1, C2 plus wiring. Why we have opted out to go for wiring as well, because C1, C2 is giving you good stability, but if you would like really rigid fixation and a high chance of fusion, adding wire is a good option, because that is stopping the rotation in the segment. And that is providing you with the most rigid, one of the most rigid segments, most rigid constructs that you may consider. And this is what was the best option for us. Of course, speaking about the safety, we decided to go and see. You have to go and see the anatomy. We have seen the course of the vertebral artery, and then we have decided that we have enough bone for doing this. We use navigation for this, and we managed to achieve good results. And thank you. That was it from me.
Jibran, please carry on. You can share your screen. And this
can I make comment on this, Salman?
Yes, please.
Yeah, so this is a very classical case of hangman fracture as we know it. So there is no confusion about what is the issue. Issue in this case is there is a fracture of the pedicle of C2. Fracture is here in the pedicle of C2. Now, when the C2 pedicle fractures, it is like lumbosacral listhesis. When there is a pars fracture in lumbosacral, the L5 goes in front. It is like a listhesis of C2 over C3 because of the fracture of pedicle of C2. Now, there are two considerations that we have to make here in this case. One is whether C1, C2 joint can be preserved and can be saved. And the other consideration we have to do is whether C2-3 joint can be saved. So there are two considerations. One is whether C1, C2 can be saved, or whether C2-3 can be. Essentially, what we have to do is there is a fracture of the pedicle, and this fracture of pedicle has to be fixed. You can put just one screw which goes right into the pedicle from one fracture end to the other fracture end, and that may be the end of the story if your C1, C2 joint is quite okay and C2-3 joint is quite okay. But in this case, what I can see is the C2-3 is quite an unstable situation. Also, I'm not sure because I don't have the images of C1, C2 joint. My technique of treating with this problem will be C1, C2, C1, C2, and C2-3 fixation from behind. So that is what I do in such cases. I try to avoid C2-3 fixation even in such kind of listhesis if during operation I find this C2-3 quite stable. So that is my answer to this question. So there are three types of treatment. One is only pedicular screw, one is C1, C2 fixation, and one is C2-3 fixation, and one is C1, C2, C3 fixation, depending on the situation of the hangman fracture. So
Atul, in case you go on MRI scan and you see that C1, C2 joint is okay and there is no problem there, and you have this case Would you consider anterior C2, C3 fixation or only as a standalone option, or you will still consider posterior?
See, as I mentioned to you, Joachim, I used to do a lot of anterior surgery earlier in my career, to the extent the first implant, metal implant from clivus to C3, from C1, C2, the metal fixation was first described by me earlier. I used to do a lot of anterior surgery, but for last 20, 25 years, I have completely abandoned anterior surgery for craniovertebral function stabilization because of various reasons. Because when I go from behind, I can analyze the situation. I can see whether they are stable or unstable. I can have a wide exposure. I can have multiple joint exposure, and I can do under my vision. And, also because, my advantage is, Joachim, that you probably don't have. I have operated more than 3,000 cases of craniovertebral junction instability from posterior root, anterior root apart. So that is my advantage. And that advantage gives me a posterior preference. So that is my answer, Joachim, to your question.
Thank you. That's a good comment. If you have, and we know that you have a vast experience in that region, and at the end of the day, whatever works in your hands, the best. And surely, if you have this big experience, then that will work the best in your hands.
Yeah, I think we move on, Nikolay. We're just running out of time.
Okay.
Jibran, please carry on.
Moving on to C1. This is a ring-like structure with a canal diameter of up to 3 centimeters. It's important to know that 1/3 of this canal is occupied by the dents and 1/3 by the neurological structures. A canal diameter of less than 13 millimeters in the AP direction is usually considered pathologic. So C1 has a dorsal and anterior arch. The dorsal arch has a posterior tubercle for attachments of muscle. And this is usually a rudimentary spinous process. On top of the dorsal arch on the superior surface, there exists a sulcus arteriosus, through which the vertebral artery and the C1 nerve travel. The laminar height of the posterior arch is about 6 millimeters. The ventral arch forms a synovial joint with the C2 odontoid process over here. And the dorsomedial wall of the ventral arch has an attachment for the transverse atlantal ligament. These two arches are connected by the lateral masses that have a width of up to 18 millimeters and a depth of up to 22 millimeters. The articular surfaces, both superior and inferior, are concave in nature. So in the diagrams, we can see the purple, which is the posterior arch, green, which is the anterior arch, blue is the lateral mass. The blue arrow is the direction of the lateral mass that it goes through. And then in red, we can see the vertebral artery, and yellow, the C1 nerve. Just lateral to the lateral masses, we have the transverse processes, which occur bilaterally. Right in the middle of it, we have a foramen transversarium through which the vertebral artery runs. And this usually turns 90 degrees medially after exiting to travel into the sulcus arteriosus, as shown in the image on the right. This part is usually 2 centimeters from the midline. It is important to know that anteriorly, we also have the hypoglossal nerve as outlined here in pink, and the internal carotid, which is just 3 millimeters anterior to the transverse process. So it can be damaged if our bar screws are a bit long. This is the Goel classification of atlas fractures. It is divided based on where the fracture occurs, whether it's the anterior arch, posterior arch, a combination, the lateral masses. And type 3 is usually divided into 3A and 3B, depending on whether the transverse atlantal ligament is injured and where it's injured. So when placing C1 lateral mass screws, we have 3 techniques: Goel, TAN, and notching. The C2 nerve usually has to be mobilized. As you can see, the C2 nerve is right at the superior C2 articular facet. And while mobilizing this nerve, we can usually have extensive venous bleeding. The screw dimensions require at least a 15 millimeter bony purchase. However, the screw length can be longer for easier connection to the rod or the constructs. And the screw diameter can be up to 3.5 to 4 millimeters. This shows the 3 different techniques of inserting a lateral mass screw. And with each technique, the entry point is more or less the same, but slightly different. where here we have it right at the posterior arch. At the notching technique, it's just inferior to the posterior arch, and with Goel's technique, it's a bit medial. And with consideration to the entry points, the angulation has to change as well, respectively. So the more lateral the entry point is, the more medial you have to go. Here's a post-op picture of C1 lateral mass screws. And as you can see, it enters from here and it's directed towards the anterior tubercle of C1. Here's a cadaveric picture that shows the direction of the C1 lateral mass screw, and we can appreciate the vertebral artery above, the C1 nerve above, and the C2 nerve below, which can be damaged by this procedure. So we can have certain variations here as well. You can have the presence of an arcuate foramen as outlined by the yellow line over here. This is because the atlanto-occipital ligament, which roofs the vertebral artery, becomes calcified, and then this groove turns into a tunnel. Therefore, it may be dangerous during a posterior approach if we haven't recognized this. In the bottom right, we can see an X-ray within the yellow circle. We can see a small foramen, which is the arcuate foramen. In up to 4% of people, we can also have occipitalization of the atlas, as shown in the pictures on the left. And we might also have a posterior arch defect in 2% of people. So you have to be very careful while dissecting this region. Here is case number 3, 43-year-old with a history of motor vehicle accident and no neurological deficit. So if anyone would like to discuss this case, a bit short because we have quite a bit of presentation left.
So let me give my view. This is a lateral dislocation of the, when there is bifid atlas or when there is a fracture of arch of atlas. What happens is the atlas facet goes lateral. You see, there is a lateral dislocation. In this situation, when there is an arch of atlas fracture, C1, C2 joint is the issue. You have to just do C1, C2 fixation. And the answer to the question in this case is you have to do C1, C2 lateral mass fixation and solid fixation. You don't bother about the occipital C1. So that is what I have to say about this.
Thank you so much, Atul. That's a good comment. So Jibran, do you want to continue?
Yes, I'll continue. Moving on to the last bone, the occipit. It has a central large foramen called the foramen magnum, which permits crossing of the medulla oblongata and cord. The anterior portion over here, outlined in red, is formed by the clivus. By the way, this is the superior top-down view of the occipital bone. The posterior portion is formed by the squamous portion of the occipital bone, and laterally we have the pars lateralis, and green we can appreciate the occipital condyles. The foramen magnum may also exist in various different shapes. So anteriorly, we have the clivus, which forms a declining angle with a concave surface. It extends from the dorsum cellae till the foramen magnum, and the pontomedullary junction of the cord usually exists at the last 1 centimeter. It can be divided into 3 portions. It's just important to know the upper 1/3 is sphenoidal, and the lower 2/3 is occipital. Laterally, we have the occipital condyles that have a projection that are projected laterally as well. They circumscribe the anterior half of the foramen magnum, and they articulate with the C1 concave articular surface to allow slight flexion and extension. If you notice the yellow circles, this is the hypoglossal canal. It exists superior and medial to the condyles at the junction of the middle and posterior third of the condyles. And just laterally to the condyles, we have the condylar canal through which emissary veins and meningeal branch of the occipital artery travel. This place can have variations in its anatomy as well. So on the top left, we have normal. On the top right, we have extension of the condylar tubercles. In the bottom left, we have a third occipital condyle in the middle. And in the fourth image, we can see ossification of the ligament of the odontoid process. The Anderson and Montesano classification divides these fractures into 3 types based on whether it's communicated or whether there's a presence of a skull-base fracture extending into the condyle or whether there's condylar bony avulsion. Type 3 is usually associated with ligamentous avulsion, which makes it unstable and usually requires operative stabilization. There is a more clinically oriented classification made by Tully. It is basically divided into two types based on whether the fracture piece is displaced or not. And then the second type is further divided into whether there's ligamentous instability or not. So in the top row and in the bottom row, we can compare Anderson and Montesano-Tully classifications, where type 3 Anderson can be divided into type 2A and type 2B. Then moving on to atlanto-occipital dissociation, that has been classified by Trenelis into type 1, which is anterior, type 2 vertical, and type 3 posterior displacement. So we can form occipital plating when the construct is required to be extended superiorly. It is important to know where to place our occipital screws, and for that it's important to know the thickness of the occipital bone. So the thickest part of the occipital bone is usually at the torcula, and this thickness decreases as we move away radially. It's highest in the midline and lowest laterally. Placement of screws in the thicker part of the squamous bone allows for increased pull-out strength and a stronger construct. Unicortical or bicortical screws may be placed. However, unicortical screws prevent bleeding and also have a reduced chance of CSF leaks. The type of implants we can place are an occipital Y plate as shown on the left, and then we can also have occipital plates or a rod system that are double in nature. An alternative option is condylar screws that, as you can see, the entry point is 2 millimeters above the C0, C1 facet joint, 5 millimeters from the medial edge of the condyle, and angulated up to 22 degrees medially. However, there is a risk of vertebral artery injury and hypoglossal nerve injury on this, along with other associated neurological structure injuries. Here is another case, a 60-year-old female with history of fall onto head from 10 feet with no neurological deficit. Would anyone like to discuss this?
Nikolay, what do you think?
Yeah, so I think this is this will be type 2 for me, and I will definitely treat that conservatively. I don't have other pictures, but from what I see here, I think that I will treat this this case in a color.
Yeah, I will just make a single comment. See, occipital atlantal joint is the strongest joint in the body, and atlantoaxial joint is the most mobile joint of the body. So dislocation of occipital C1 joint is an absolutely uncommon situation. When I say I have done so many C1, C2, I have never actually identified ever occipital C1 instability, never. And this kind of minor fracture of condyle and this and that can be completely, absolutely treated conservatively. And there is no question in an asymptomatic patient to touch this. So that is my answer.
Okay, moving on.
Yeah, thank you.
Okay, moving on to the ligamentous structures. These span from the odontoid till the occiput, and their function is to restrict excessive motion and provide stability to the CV junction. The most important ligament of the CV junction is the transverse atlantal ligament, as shown in the upper picture in red. This binds the dents to the C1 anterior arch and prevents cord injury during flexion by movement of the dents posteriorly. It provides substantial contribution to the stability, and if ruptured, it results in instability. The thickness of this ligament can be up to 7 millimeters. Centrally, it is composed of strong elastic collagen fibers. However, laterally, it is composed of fibrocartilaginous tissue, and this is the area where it is most susceptible to traumatic rupture. From the center of the dents, it has superior and inferior crura as well that attach to the foramen magnum and the C2 body respectively. Here is an axial cadaveric section where the transverse atlantal ligament has been outlined in blue, and this shows that it prevents the movement of the dents posteriorly. So the transverse atlantal ligament has been classified by Dickman into two types of injuries. Type 1 is where the ligament ruptures in the center. This usually does not heal and requires operative stabilization. However, with type 2, we have a tubercular avulsion, as we can see and appreciate here. The ligament is intact, however, the bone is broken, and in this case, up to 80% of patients can heal with just external immobilization. The alar ligaments occur bilaterally, and they arise from the lateral portion of the dents to attach to the medial occipital condyles. They restrict rotation and contralateral bending and are an important stabilizer. They are just as strong as the transverse atlantal ligament. The apical ligament, however, is absent in up to 20% of patients. It arises from the tip of the dents and attaches to the foramen magnum. It has an unclear biomechanical significance and the least contribution to stability, because in physiologic flexion extension, it does not have any ability to resist this motion. However, it may serve to prevent translation of this junction. Here again is a cadaveric view, where we can appreciate the dents centrally and the alar ligaments arising bilaterally to attach to the medial occipital condyles. Superiorly, we have the apical ligament, and just inferiorly, we have the transverse ligament, which binds the dents in place. The tectorial membrane covers most of the ligaments of the CV junction posteriorly. It arises from the C2 body to fan out over the dents and associated ligaments to cover them, and then attaches to the upper surface of the clivus and incorporates with the dura over here. It has a very controversial role. However, it may allow redistribution of forces over the ligaments to keep the dents in place. Next, we have the anterior atlanto-occipital membrane highlighted in green. This is the superior continuation of the anterior longitudinal ligament, and it connects the anterior atlas tubercle to the base of the occiput. This fuses laterally with the articular capsules, and this also gives the least amount of stability to the CV junction. There are certain other ligaments that are not as important but are important to know. The accessory atlanto-axial ligament highlighted in red bilaterally connects C2 anterior-medially with the foramen magnum over here. It has no contribution to stability, however, it can restrict rotation and flexion. Then we have the articular joint ligaments of C0, C1, and C1, C2. These are synovial joints with ligamentous capsules, and these merge with the atlanto-occipital membrane as mentioned previously. The last two ligaments, the posterior atlanto-occipital ligament from the occiput till the arch of C1. This is basically a homologue of the ligamentum flavum that we can see inferiorly between C1 and C2. As we can appreciate here, they are punctured by the vertebral arteries along with the C1 nerve, and the dura mater is just underneath this membrane and it is usually very adherent to it. So this is a video of a 3D model video of the ligaments. Here we can appreciate the ligamentum flavum over here, the C0, C1 articular capsule over here. And then if we hide the atlas, we can appreciate the apical ligament centrally and the alar ligaments laterally. The tectorial membrane and cruciate membrane are not visible yet. And this is an anterior lateral view. Moving on to the nerves. The C1 nerve, as labeled over here, it exits superiorly along the C1 posterior ring in the sulcus arteriosus, along with the vertebral artery. This groove is formed by the elevated superior articular process, as we can see here, and it is roofed by the posterior atlanto-occipital ligament, and it is at risk while placing lateral mass screws in C1. The C2 nerve, as labeled over here, exits posterior to the superior articular facet of C2. The branches of this nerve course superior medially posterior to the CB junction to form the occipital nerves, and this is usually at risk while placing C1 lateral mass screws and C2 pedicle screws. Sinovertebral nerves arise within the intervertebral foramen and are recurrent in nature, which means they travel back into the spinal canal, the immediate pain from the associated ligaments, dura, and disc. Here is another video showing the neural anatomy. So we can appreciate C1 leaving atop the C1 process, C2 leaving atop the C2 process. It's important to know that at the intervertebral foramen, they divide into anterior and posterior rami. The anterior rami go and get involved with the cervical brachial plexus, and the posterior rami usually form occipital nerves and nerves for the dorsal musculature. It's also important to know that the vertebral arteries exist at this level. They exit from, it's highlighted in pink over here. They exit the C1 transverse foramen to travel along the upper surface of the C1 arch along with the C1 nerve root. It has multiple branches, osteoarticular, meningeal branches, branches to the spinal rami, and they form the anterior and posterior spinal arteries as well. It is dangerous during posterior dissection while we're dissecting about 2 centimeters laterally from the midline along the lamina, or if we're drilling the base of the superior articular facet of C1. And as we can appreciate here, just anterior to the transverse process, we can see the internal carotid artery, which is about 3 millimeters distant. The arterial supply of the CV junction is mostly from the vertebral artery. These branches of the vertebral artery arise at the C2, C3 level and travel within the spinal canal. Here we can see a highlighted pink ascending branch of the vertebral artery. They supply both the C2 and the C1 bones and the dents as well. You can note over here the position of the internal carotid artery, which is just anterior to the C1 arch. To the C1 transverse process. So as previously described, the risk of vertebral artery injury is highest when there's an anomalous course, especially when it's unrecognized. Then the screws, the most riskiest is the transfacet screws, with the translaminar screws being the least riskiest. Here we can see an axial cross-section of a CT with the dominant left vertebral artery. So if we see during placement of a C2 pedicle screw, it is very likely that we might damage this side of the vertebral artery. Here is another video showing the arterial supply. So C1 exits C2 and enters C1 transverse foramen, then travels medially and pierces the atlanto-occipital membrane. Here we can see the nuchal ligament highlighted along with the posterior atlanto-axial membrane, through which the vertebral artery pierces to enter the spinal canal. Here we can see the superior and inferior crura of the cruciate ligament. And if we take that off, we can see the internal ligaments, apical and alar ligaments. Yeah, how do we know whether to perform a CT angiography of the neck? The Denver criteria was developed for this, and it assesses certain signs and symptoms as well as certain risk factors, the most important of which is a high energy transfer mechanism, plus any one of these unstable facial fractures, skull-base fractures, or other associated cervical or thoracic injuries. Moving on to muscles, they can be divided into unisegmental or multisegmental muscles, depending on the segment spanned, their depth, where superficial muscles usually initiate motion and deep muscles act as stabilizers. They can also be divided by location. So first we'll talk about the posterior muscles from superficial to deep. The most recognized one is the trapezius. Laterally, as highlighted, is the sternocleidomastoid. Just deep to that is the splenius capitis, then the semispinal capitis, then the suboccipital musculature from medial to lateral, highlighted in yellow, is the rectus minor, then in black, the rectus capitis major, then in green, the oblique inferior, and in blue, the oblique superior. The red muscle is the longissimus muscle. The suboccipital triangle, as highlighted in purple, is a very important anatomical landmark. It shows us where the posterior arch of C1 is, the V3 segment of the vertebral artery, as well as the C1 nerve. Further deep inferiorly, we have the spinalis muscle arising from the C2 posterior spinous process in yellow, then the semispinalis in black, then the multifidus in blue. And here in green, we can see the inferior suboccipital triangle, which is a landmark for the V3 segment of the vertebral artery, the inferior portion, as well as the C2 nerve. Further deep, we have the interspinalis coli in between the spinous processes, and then we have the intertransverse muscles between the transverse processes. Here's the lateral view of the intertransverse muscles, and then we have the rectus capitis anteriorly in yellow, the lateralis in green, and then we have the condylar triangle, which shows us where the anterior third occipital condyle triangle and the V3 segment, and this is also a landmark for the hypoglossal canal. It is bounded by the rectus capitalis lateralis, the superior oblique, and the bony landmark between these two muscle insertions. Anteriorly, we have the longus colli attaching to the C1 tubercle, which is covered by the longus capitis that attaches to the occiput. Then we have laterally to the transverse processes, the scalenus medius, the splenius colli, the levator scapulae. And this is a video showing posterior to superficial deep dissection of these same muscles. Here we can see the highlighted vertebral artery. Then the vertebral artery course was appreciated right there. Moving on to biomechanics, the primary motion at the CB junction is rotation, which occurs mostly at the C1, C2 space segment, with minimal rotation occurring at the occipital cervical junction. It is important to note that if rotation occurs at more than 30 degrees, the contralateral vertebral artery making, whereas at more than 45 degrees, the ipsilateral vertebral artery is occluded. The C1 body is absent. Developmentally, it fuses with the C2 body to form the dents, and this allows the rotatory movement at this segment. Rotation is restricted by facet lock that occurs at 40 degrees because of joint capsule as well as the alar and tal ligaments. In flexion and extension, the occipital cervical segment provides the most degree of movement. However, this is limited in flexion by the dents in C1 abutting against the foramen magnum, whereas extension is limited by odontoid contact with the tectorial membrane. At C1, C2, flexion extension can also occur. However, this is limited by the tal and the facet joints respectively. Lateral bending does not really occur at the CV junction. It is very minimal, and it is usually restricted by the ligamentous and bony anatomy. Translation, distraction, and compression are not physiological movements of the CV junction, and they're restricted by various ligamentous and osseous structures. It is important to know that movement in the spine, at any level of the spine, occurs as coupled motion. So there is no such thing as isolated flexion or isolated bending. Movement in one plane usually results in movement in the other two planes of motion, as shown in this diagram, where left lateral bending is associated with both flexion anteriorly and rotation. Moving on to pathological motion. If pathological flexion occurs, the tal can usually fail at the cruciate ligament or at the odontoid waist. This is basically an all or none phenomena where even a minor tear can cause catastrophic failure. The tectorial membrane also limits flexion, and therefore it is damaged when pathological flexion occurs. Hyperextension usually causes fractures of the posterior C1 arch or the C2 pars or odontoid, and anterior CV junction ligamentous shear injury can also occur. Hyperrotation is usually associated with alar ligaments or synovial joint disruption. This is very rare and usually occurs in conjunction with either flexion or extension injuries. Traumatic compression also rarely occurs in isolation. It is associated with osseous fractures like C1 burst fractures or occipital condyle fractures. On the right, you can see that compression fractures do not occur in isolation. They're usually associated with some element of flexion or rotation. And according to this, we can have different fracture patterns. So it is important to assess the stability of the CV junction because of the large amount and more important neurovascular structures present in this region. The more commonly known one is the Powers ratio, which is a ratio between the distance from basion to C1 and opistheon to C1 ventral arch. The normal average is about 0.77. However, it is considered abnormal if it is more than 1. It is important to know that this does not tell us about posterior or vertical dissociation. The Harris method has a higher diagnostic accuracy. It consists of looking at the basion and dens interval as shown in red over here, from the tip of the dens to the basion, and then the basion axis interval. The green line is the posterior vertebral C2 cortical line, and then the distance from this line till the basin is called the basin axis interval. It can be in positive numbers. If it's more than 12 millimeters, it can be abnormal. It can also go into negative numbers. if this basement travels posteriorly. Then there are other measures such as the anterior atlantodental interval, the posterior atlantodental interval, and the spinolaminar line as shown in this picture. We can look at the C0, C1 interval. We can also assess the condylar sum by adding the average of both of these distances. This is a cadaveric section showing multiple other lines that can be used to assess the CV junction. There are quite a lot of these. Not sure that I should go into all of them because of time constraint. However, it is important to note that we should choose only a few of these that we are more familiar with, and then base our practice based on that. So in conclusion, the CV junction is a complex anatomical structure with unique articulations. The biomechanics are dependent on the unique anatomy of this junction. It is a transitional zone where load is transferred from the cranial to the subaxial cervical spine, and different components with different orientation and properties lead to different biomechanics. It is essential to know that understanding the anatomy of this region improves surgical safety. Early identification leads to early and appropriately timed treatment, which prevents urological morbidity. Thank you. These are my references. I'm going to stop sharing my presentation now.
Nikolay, you're on the walkabout. Hi, guys.
I think we lost him.
Okay, no worries. Joachim, you want to take over as moderator with Ruli?
Well,
Yeah.
I don't know exactly what is the next step. So I think this was a very nice anatomy presentation. I think it's perfect to really divide.
Yes, so much, Jibran. It was amazing, very good, very good. Hello?
He's back. No, he's muted. Okay, so I think it was very good to divide the anatomy in muscles, in vessels, in bone, in joints. I think this is a very nice approach and brilliant pictures. So I don't think that we have any questions about this anatomy part. Really, what do you think? You want to add something about the anatomy? I think the next step is, this was the last case, right? The next step would be Atul with his presentation.
I think this presentation was excellent, and I don't know if any audience have a question about the presentation.
I think
The only thing I saw on the chat is that they asked for the program you prepared the presentation with, you know, this anatomy video.
Yeah, the program I used was Essential Anatomy, that is available on Apple, and for Android you can go for Complete Anatomy. They are both by Elsevier.
Can you put it in the chat?
I'll show the screen.
Okay.
Okay.
So here we have the Complete Anatomy app right here for Android, and then Essential Anatomy app for Apple. Is it visible to everyone?
So I picture this myself. Very nice. So then I don't see any other questions. So I think we should move on.
Sure. Let's move on.
Rolly, you want to introduce Atul, or should I do it?
Maybe you can do it.
So it's a pleasure for me to introduce Professor Goel, who is a real
he doesn't need to be introduced
surgery
anymore.
of the cervical junction, and I think it's perfect that we have that you have found time to present your experience with the C1, C2 stabilization from posterior.
Thank you, Joachim, and thank you, Salman. Can you see my slides? Can you see my slides?
Yes, yes.
Yes, yes.
Okay, so I'm going to
Yes, it's
talk
clear.
on, in 10 minutes or maybe a little bit more on surgical anatomy, little bit, not too much, it is too big, and we have already heard a lot about it. So one thing I have to say, you see the beautiful faces, the king-like faces following atlantoaxial fixation. This is a wonderful, wonderful surgery. Nobody in contemporary neurosurgery or spine surgery can say, no, I don't want to do C1, C2 fixation. If you do not do, you miss this beautiful smile. You give new life. You completely give new life. You have to do this properly. That is the bottom line. So this is the technique, C1 screw, C2 screw. Screws, you see these screws. In 1987, screws were not in the neurosurgical domain at all. Facets, not many neurosurgeons understand facets till date. And atlantoaxial instability, I must say, and you please listen to what I'm saying very carefully, atlantoaxial instability is the most under-recognized and under-treated clinical entity in our subject. Under-recognized and under-treated. So as you know, this is the technique we described in 1987. One screw in C1, one screw in C2, and this picture is from my original monograph, which was published in 1994. And you know this technique now very well. So this is the magical C1 and C2, the king junction. Now you see carefully this facet of C1, the superior facet of C1. See how rugged it is and how big it is, how big and rugged. Rugged because many ligaments are attached to it, and big because occipito-atlantal joint is the most stable joint of the body, most stable. It cannot, according to my calculation, it just cannot get unstable. And now you see the C1 facet. The superior surface of C1 facet is round and has smooth. You see, there is no ruggedness here. This is the most mobile joint of the body. There are circumferential movements, and this joint is the most mobile and the most unstable joint of the body. And this beautiful bone that you see is called the atypical bone. It has the largest spinous process of the whole spine. C1 has the largest transverse process of the whole spine. So this movement, which rotatory movement, occurs at this joint, and flexion, extension, and all other movements occur at C1, C2 joint. So facet of C1, you see the beautiful round, it is like a tooth. You see, you call this one as dense. Dense means tooth, but the strength of the facet is stronger than the dense. So this is the strongest bone of the body, and it gives very beautiful access to the screws. There is no question about it. So my technique, there are three components. One is to open the joint, one is to remove the cartilage, introduce bone graft in the joint, and then do C1, C2 fixation. These three components are absolutely necessary. You cannot do one component and not do the other two or other three components. C2 nerve root is placed right in front of the joint. You see, right adjacent to the atlantoaxial articulation. So we described C2 nerve section very early in 1988 in that article. And according to me, this is a window to the atlantoaxial joint. I do not do C2 sectioning now, extremely rarely, but this gave a window to the joint and opened the entire lateral mass to C1, C2 fixation. As we know, anatomy is critical, anatomy is absolute in this because of the vertebral artery. Vertebral artery can be like this and can leave the entire articulation free for you, or on extremely rare occasion can go right medial and occupy the entire C2 facet. So you have to know the anatomy without any doubt and without any question if you have to do this technique. We suggested that you draw 9 quadrants here, and the medial and the uppermost quadrant are more suitable. So these quadrants are more suitable. So this is what we had said earlier. Inadequate or inappropriate insertion of the C2 screw can lead to disaster, and vertebral artery injury is the more dangerous issue in this. And you have to, if it happens, it happens. I'm not saying it will not happen, but if it happens, you have to know how to handle that situation. So medial and superior. C2 screw has to be medially directed and superiorly directed. You can use navigation and it can be of help, but I have to tell you that I don't use navigation now for a long time. This head high position under traction is very important because venous congestion, there is a huge venous congestion in the lateral mass, and that can result in very significant bleeding and difficulty in exposure of the articulation. So this head high is a good position. So one screw in C1, you can make several permutation and combination in this fixation. So what we have done here is double insurance, one screw in like a Megal's technique and one like C1. I don't use it often, but sometimes it may just be necessary. This is the vertebral artery which goes medial, and you see there is a very thin bone in front when you see from anterior perspective. Similarly, very thin bone when you see from posterior perspective. So you have to know that the vertebral artery can be very severely anomalous in the craniovertebral junction, particularly in craniovertebral junction anomalies. And these are the 3D models which we make now for more complex situation. And those models can give you perfect information about the location of the vertebral artery. You see, this is located behind the C1 facet. And this happens on a number of situations. So if this happens, you have to mobilize and all those things. This part of the artery, you have to mobilize, you have to push it down, you have to push it medially, depending on how you want to do it. And then you have to do this under vision. Nothing can be done without vision. Blind situation is not a good. You see, this is vertebral artery foramen, such a huge foramen. If you know the anatomy of the vertebral artery beautifully with these 3D models, and you can keep those models right by the side of your table, you can sterilize this model and you can use it during operation. So you know that you have to put your screw here and not here and not here, because this is a dangerous situation. So these 3D models, we described the use of these models few years ago, and I think these are wonderful models. So this is the bone in contention. This is the facet of C2. This is the vertebral artery foramen. This is the pedicle. This is the pars. This is the C2 spinous process. So your screw has to go like this. It does not look dangerous when you look like this, but vertebral artery goes like this and then turns like this. So this is the superior facet of C2. This is the inferior facet of C2. See, this is anterior, this is posterior. This is the difference in this vertebra from rest of the vertebra. C1 superior facet is far anterior. So when you do the fixation, you put your screw in the C2 superior facet, but you do not, you see, in situations where the vertebral artery is very high, you can use C2 inferior facet. So that is one new thing that we had recently described, C2 inferior facet. And you can use C2 inferior transarticular to C2-3 fixation. So this inferior facet can be useful when the vertebral artery is quite high. So you see this case, the vertebral artery is very high, and I have used C2-3 inferiorly directed screw, and this is in C1. So this is also very useful, not always, but frequently you can use. There is a very high assimilation of atlas. One screw has gone, and there is a, you see the lateral masses of C2 is very destructed. So I have used the inferior facetal screw. So vertebral artery goes like this. You can actually mobilize the vertebral artery out of the foramen. So this is the technique that we recently described. You drill this area when you are coming from behind, you can drill this area very gently and very easy. I will say easily, should not be used this easy word, but you can use drill it and mobilize it. And then you can put the screw. And that is possible on a number of occasions. You see very high vertebral artery, very high vertebral artery. So what we have done is mobilize it inferiorly and then introduce the screw in the C2 facet. Also, sometimes, in assimilation of atlas, the atlas may be very high. Another thing I have to tell you is I have completely abandoned occipital fixation. Occipital fixation does not appear in my dictionary now. When I describe first time occipital screws in the literature, but I don't do it. You see, this is very high C1. So I do a smallish craniectomy here, and then extradurally, I identify the C1 facet. So this is the transcranial route. After doing a little bit of a craniectomy here, you see some craniectomy is done, and then you have introduced the C1 screw. So that is possible in some situation. Here I have gone transcranial here and trans C2-3 here, and I have done transarticular. So there are multiple, you have to use multiple permutation and combination to do this. Another thing which you probably don't know is that I describe laminar screws first. Spinolaminar screw, spinous process screw, spinal laminar screw. So this was the article 2004. We described this first, and you see this was in the paper. I do not do this technique now, but this, as Jibran described, laminar screws can be used. Other thing I told you that I have described occipital screws, but whether these screws are necessary or not is a controversial issue. In this neurosurgery article, I said that occipital screws are required in absolutely never. So other thing which last sentence which I want to show it to you is there are huge number of muscles attached to the C2 and C1, C2 basically. So if you are coming from anterior, these muscles remain active and they can disrupt any kind of metal implant that you have put from the front. So when you are doing C1, C2 fixation, you have to cut these muscles. If you do not cut these muscles, they are so strong, they can disrupt any kind of implant that is put from the front. Last thing, if you want to see, is joint jamming technique that we had described. So that's it. Salman, you gave me 10 minutes, and I think I have not upset you. Usually I upset people with these kind of, going beyond my time. So thank you.
Thank you, Rudy and Joachim. You are the moderators, please.
As always, Professor. So maybe from the all faculty or audience wants to ask Professor Atul or comment, please.
Rudy, you can move on, and then if there are any questions, we'll take them.
Oh, okay. So we can move on to another lecture.
Well, I want to comment something. It's always a pleasure to hear you, Atul. And obviously, and well, I think it's very good to make life easy and simple. And it's really a pleasure that that you make everything simple for C1, C2 posterior Atul Goel approach. And well, unfortunately, I'm still not at your level. You have to educate. I think I need 10 more years, Atul.
To receive these comments from you, from a very eminent and very elegant neurosurgeon of the world, it gives me great pleasure, and it is a big honor to hear from you, Joachim. Thank you.
So shall we proceed?
Yes, please. We are running short of time, please.
Okay, I think I'm next, right?
Yes.
Yes.
Okay, let me see. So should I just share my screen?
Yep.
Let's see. No, I don't see my screen. Why is it not working? Yeah, now it's working. You see my screen?
Yes.
Yes, you hear me? That's very good. So it's a pleasure for me to present a different perspective. And well, we will not find out, but when I was informed what is my topic, it was anterior transarticular screw fixation. So, well, this is, I thought, wow, now they really want to kill me. And well, I went over our 300 craniocervical junction procedures in the last 10 years, and I found out some very few we did transarticular anterior screw fixation. So I will give you a brief description of this technique in our hands. I have to disclose, but I mean, this topic was never supported by any company because it's so rare. And this is where I'm from this southwest Germany. And well, right now we are discussing that in the mid of April, everybody who has a COVID vaccination twice received already will be probably able to travel to Germany without quarantine. So maybe we meet soon again. So this is the department. And this is my topic. So anterior C1, C2 transarticular fixation. I will divide my presentation: history, surgical technique, advantages, disadvantages, and own results. It's very rarely applied, at least in our hands, and it's rarely discussed. It was prescribed about 50 years ago. And then once in a while, every 3-4 years, I see a description of some nuances on this technique. So most recently, I read about it in the German Central Neurosurgery journal about another variation, but I have not included this in this historical perspective. So what do we talk about? It's actually a little bit like an odontoid screw, but it's not odontoid screw. It's a little bit more lateral. You go from the base of the odontoid of the C2, a little bit lateral through the lateral through the joint, and then do an anterior transarticular fixation. You see, this is a case series from China, but this is pretty much what we have on the literature right now. Well, what is important for the screw fixation, you cannot use the standard odontoid screw because the standard odontoid screw usually has a thread only at the top and is then a non-threaded screw. So here you need a fully threaded screw because you really want to fix the transarticular, the joint with the transarticular screw. I will not go too much about anatomy because most of the anatomy we have discussed. I will just flip from posterior to anterior, and this is how this can be done. You see, this is the anterior column on the coronal section. You see, this is the base of the C2, and here's the C1, C2 transarticular portion. And when you go for the lateral image, you see that this is the base, and this is exactly direction of the odontoid screw when you want to fix the odontoid fracture. And this is almost exactly the same trajectory on the lateral X-ray for the transarticular screw. Actually, because we have only, I will get back to this later, only done 3 cases out of 300. So in our hands, for the craniocervical junction, it was 1% of the procedures is transarticular from anterior. I went to the lab because we did some lab dissection this week, and these are on the right side. These are X-ray images from a cadaver I have just prepared for these 2 screws. And you see it's important to have an ideal lateral anatomy to really identify the base of the C2 and then go lateral to the midline. And then when you go lateral to the midline, you see that the base goes a little bit upward. And then you aim exactly parallel, a little bit posterior to the odontoid tip. So here's the description of the technique. It's of the, you go to the C1, C2 base, then a little bit lateral. We never do, we go about 8 to 10 millimeters lateral from the midline. So it's just lateral to the attachment of the longus colli muscle. And then you aim 15 to 25 degrees lateral and aim almost parallel, a little bit posterior to the direction of the odontoid. You see here in this schematic drawing here how to put these screws in. What is the technique? Is a supine position. We always use Mayfield sharp head fixation. We do this procedure with the 2 C-arms, simultaneous application, so like an odontoid screw. And it's important that you don't have to do this for any reduction. So you have to have the fracture or the instability in ideal anatomical position. The skin incision is far caudal, so almost like an odontoid screw fixation, and usually at the level of C4, 5 or C5. Blunt dissection of the anterior approach, and then the identification of the C2 base and C2-3 disc. In this case, when I do the odontoid screw, I usually remove a little bit of the disc. In this case, it's not really required. You just go lateral to the base of the C2 and identify the longus colli attachment, and right where the longus colli attachment is, there you can start to insert the screw. The aiming is at the posterior part of the tip of the dents. We use usually cannulated screws, so we drill the trajectory with a burr and then inspection of the trajectory with a wobbler or wire, and then we insert cannulated full threaded screws. The length in these 3 cases was 28 to 36 millimeters. So this is from the cadaver. Here, drilling in the trajectory only lateral. I will get back to it with you with the AP view. Then you see here, this is the joint. So you do now, we enter transarticular in the C1 part. Then we use the wobbler to inspect that we are inside the bone, and then we insert the screw. And this cadaver, I had not cannulated screws available, unfortunately, but it's much easier with the cannulated screws. This is the same case in the, then the second one. This is the same case in the AP. Here you see, this is the odontoid, this is the C1, C2 joint, and this is the first screws we put in. The second screw, you see it's a little bit more cranial than the base of the C2 when you go to the midline, like an odontoid screw. And then we drill, we pass the facet joint, and then we put in the screw. And this is the result with both transarticular anterior C1, C2 screws on both sides. Short video on this. This is the cadaver we did. So we detached the longus colli muscle. This is the base of the C2. You go a little bit lateral, and then we aim 15 to 25 degrees lateral. Detach a little bit of the muscle tissue. And this is exactly the position of my dissector. And then we drill the trajectory to the a little bit lateral, and absolutely in the direction of the odontoid tip. This is a diamond burr. Then comes the guidance instrument for the K-wire or the drill. In this case, we use the drill. And you see that you aim a little bit more lateral than for the odontoid screw. For the odontoid screw, you aim medial. Here you aim lateral, 15 to 20 degrees. And here we have already passed the facet, the C1, C2 joint. And then we use the wobbler to make sure that we're inside the bone, feels good, and then we introduce the screw. In this case, I think the cadaver, the screw was 32 millimeters. As I said, I had no cannulated screw available here. We used to use for this technique the Neon 2 system, but Ulrich company is a German company. They have cannulated screws, but we hadn't have this right now. We had not this available for the cadaver. So this is the screw. Not fully inserted, now it's fully inserted. and then the other side follows. Let me see. Just want to show you, this is the X-ray. Okay, the AP, you see here's the C1, C2 joint, and here's the C1, C2 joint. Ideal position of these two screws. Where I have worked up these three cases we did so far. The first case was a type 2 fracture, including anterior and posterior atlas arch fracture. So facet joint C1 to subluxation, and well, actually, to be honest, there was a coincidence of a misunderstanding. We went from anterior, and then we did the odontoid screw, and since it was clear because of the involvement of the C1 anterior and posterior arch that this is not going to be stable, we added the transarticular screws. You see here the lateral X-ray and the AP X-ray in the theater. One screw and then the other side, nicely positioned through the joint. But already here on the X-ray, you see one problem with this transarticular anterior screw fixation, that the joint itself is wide, is not nicely brought together. So usually you have quite a gap here. And I think this is my most significant problem with this approach, is that it's difficult to really be sure that you get a stable fusion. This patient, this is the post-op CAT scan of this patient here. You see nicely positioned odontoid screw and transarticular C1, C2 anterior screws. However, 1 month later, I just did not feel comfortable, so we discussed with the patient and we went back and fused this patient from posterior. And this is the posterior screw fixation. Here you see it's transarticular screws and atlas hooks. Second case, and this is a 17-year-old female with a polytrauma, and he had a lot of fractures, but C1, C2, he had this rotational malalignment. He has a significant instability and flexion extension, lateral X-ray, and he had this gap in the anterior arch. And for some reason, we decided to come from anterior. We discussed this a lot, and the patient was not able to be put in a prone position at this part in the first days because of his other injuries, and we decided to do this with the anterior transarticular screws. You see this is the lateral X-ray from the intraoperative situation. This is the AP X-ray from the intraoperative situation. I think probably this screw, it looks to me too far medial, so I don't remember. This case is 3 years old, so I think that this screw was taken out and replaced. But on the post-op CT, you see this is the post-op CT. All screws look perfect. So I think there's one intraoperative X-ray just missing in our records. You see this is the follow-up X-ray, and this patient now is for 2 years with a stable fusion C1 to transarticular. And then the third case was a very difficult case with a lot of instability. And he had a dislocation T2, C3, he had a fracture C6, C7. He had a hangman fracture type 3 and avulsion of the C2 arch. And in this case, because we had to come from anterior anyway, and we had to fix the C2, C3, we additionally put transarticular screws from anterior, but we went on and did posterior approach as well. You see here, this was the construct for this complex cervical injury, C2, C3 fracture, discal ligamental injury, then C6, C7 fracture, and then C1, C2 hangman fracture as well. So here we have no follow-up because, well, we have a follow-up and there was a stable fusion, but there was additionally anterior and posterior fixation. So when you look at the books, what is the indication for anterior and atlantoaxial transarticular technique? There are a lot of different indications discussed. I really do not want to go into detail too much because I think what are the contraindications in the book? Well, lateral mass of C2 diastasis, patients with known difficulty of swelling and associated C1 fractures. But well, I think it's easy access, it's very convenient access, it's minimal blood loss, it's very inexpensive since you only need 2 screws and you receive immediate stability. But the disadvantages, in my opinion, are it's very difficult because you need a lot of anatomical knowledge. It's very difficult because you have absolutely no intraoperative orientation. So it's very different from a posterior approach where you have a very good intraoperative orientation when you know the anatomy. It requires 2 C-arms and you have no possibility of any repositioning. So you have to have the ideally alignment of the anatomical situation. There's no decompression possible. So you have to be sure that there's everything is decompressed. And in my hands, I think it's not possible to apply any bone graft really in a sufficient manner. And I think this is the most significant problem, since you can also not remove the cartilage because you just get not access to the joint. I think the long-term fusion rate is much less than from posterior. So pitfalls, it's difficult because you have to be sure that for the evaluation of the CATs, of the CT images, where we should not underestimate any deformity, otherwise it's not sufficient. And we need full-threaded self-tapping screws, otherwise you cannot get a stable situation. It's easily applied. Well, in our experience, it's a high rate of incomplete fusions. At least we have done 3 cases only, and well, one we did a revision because it was not felt to be 100% stable. One is still fine, the 70-year-old after 3 years, and the other one was clear, the third one, that is not a fusion of the transarticular joint. And posterior C1, C2 instrumentation is the gold standard. And only in very selected cases, we use the transarticular C1, C2 fixation from anterior. And as I said, if you want to come, we try to have our next course at the end of May. Probably is possible to visit us. You're highly invited. And I want to thank Professor Schwertfeger, who used to be my vice chairman. He is retired now. He did most of these cases from anterior. Dr. Hassanang is a spine consultant. He did the lab with me, and Dr. Nikolay, he prepared all these 3 cases for me. Thank you so much.
Thank you, Professor Joachim. Joachim is a very nice presentation. But I have one question. I wonder why we would choose this kind of anterior fixation for C2 fracture compared to posterior fixation, because many of case in our center, they're very rare C2 fracture only, because it's always need decompression. So I wonder if the anterior fixation could create a better fusion compared to posterior, like C0, C1, C2 fixation from posterior. I don't know. Do you have any idea about that, Professor?
No, I think it's more difficult to get a sufficient fusion because you don't, I mean, you really cannot apply the good bone graft. Even if you do from post have a transarticular fusion, it's easy to just open up the C1, C2 facet and then just drill it and put some bone there. Additionally, you can put bone in between the C1 and C2 arch. So it's, or next to the screws on the lateral side. It's like you have a lot of options to put bone there from the posterior. From the anterior, I don't really know, because the angulation is so difficult that you cannot really enter the joint. Okay, so it's in our experience, it's very few selected cases, but you just look up the PubMed. It was just a recent paper for combining this odontoid with odontoid screw in C1, C2 instability. So it's used, but in our hands, the indication is rare.
Okay, Joachim, I think we're going to move on because we're really running late. Ruli, would you like to introduce Victor, please?
Okay, next presentation will come from Dr. Victor from Mexico. Will introduce about presentation about spine model. Dr. Victor, please. Time's yours. You cannot listen, Professor.
Okay.
Sorry.
Yeah.
Yeah.
Yes. Okay. Can you see it?
Yes.
Okay. Thank you very much, Dr. Salman. For me, it's a fantastic, amazing webinar. And I feel honored to be with all of you in this course. So I'm going to speak about the production of some models of cervical spine. This is an anterior view in which I have done these models with they have been made in models of silicon. I take an original bone and then after I make a copy with silicon and then after with resin. So the arteries and nerves are made, they have been made handmade. Let me show you the advantage of these models. This is a posterior aspect of the cervical spine. And this resin can be drilled and then we can see the nerves, the spinal cord, the lateral mass, and we can put some screws to see direction of these screws. In the right side, we have the anterior aspect. This is a very useful technique because we can see the real anatomy of the bone. This is a degenerative spine cervical. And in here we can see the lateral aspect and posterior aspect. This is another view. And then we can do some exercise in cadaver workshop. So this is also very useful for beginners, not for experts like all of you, but for residents and young neurosurgeons, this is very useful. And here we have some landmarks in this cervical spine. So here we have a real bone, and I take this real bone. I make the mold silicone, and then I put resin, and I get this kind of bonds. So the advantage of this is that we can make exercise with these bonds. So in my country, it's not easy to get real bonds. So some years ago, I decided to make a copy of these bonds, and I can reproduce so many vertebral bonds. This is very important to avoid to enter to the spinal canal, to the vertebral canal, and to respect the cranial, these cervical nerves, and also the spinal cord. Here we have another short video to see the advantage of these models. To go into the right direction. C1 lateral mass screws are best placed beneath the posterior arc, and with 20-degree medial angulation will increase the safety margin to make this technique. So this is another beautiful picture of the posterior spinal cord. And I think the spine surgeons need to know the bone, the anatomy, the real anatomy of the bone. And then after, if we make a dissection in cadaver workshop, we can get these pictures. Here we have the vertebral artery and the C2 cranial nerve. These are another pictures of these bones, and this is a posterolateral aspect of this model, the craniovertebral junction. This is a short video to show this anatomy. With these models, we can exercise. I'm going to resect this lateral, this transverse process. And then we can mobilize this vertebral artery. If we work with these models, and in the same time we are dissecting in cadaver workshop, is really useful. We can get some skills. We improve our abilities to make this difficult surgery. The vertebral artery travels to the lateral mass, then crosses medially over the C1 neural arc. This vertebral artery could be at risk during instrumentation. So medially, we have the spinal cord and also the cervical nerve roots. This is a picture about this, but if we see it in a real aspect, is very impressive to see this kind of anatomy. Let's going to put again. This is the posterior aspect.
Victor, we have two
Yeah.
more minutes because we have to close this the webinar at 4.
Yes.
Okay, and we need the multiple choice questions and everything.
Yes. Thank you so much. This is another exercise to make this screw, the anatomical side to put these screws. This is another picture of these models. They have been injected with silicone. And then we have these models. We can get some skills also in skull base, in craniovertebral junction. This is some exercise in workshop, cadaver workshop. This is the model, and this is a dissection. Okay, this is what I wanted to show you about the elaboration of these spine models. Thank you.
Wonderful, wonderful presentation, Victor. Any questions to Victor? I didn't see anything in the chat. Did I miss something?
I think it was excellent. Really enjoyed those and dissection. And if you know things beforehand, then everything, it's just practice, and it's brilliant. And the models are brilliant as well. Thank you, Victor, for wonderful, wonderful presentation.
Thank you, Salman Sharif.
Okay, so you have to do the quiz now.
Ahmad, can you share the...
In the chat is the internet address. And did we do a screenshot? Did we do a shot of all the participants, someone?
We can do it now.
Yeah, but they are all muted. Look at this.
So we will get all of them to open up. Okay. Atul, you want to take these questions? They are yours.
Atul is also muted. I think I just go ahead. I
Sure.
can read them.
Okay.
But I cannot go up. Is this the first one? The vertebral artery has a close relation with what portion of the C2? Vertebral body, pars, superior facet, inferior facet.
Okay, you can read them and then we can see the results in the end.
Yeah. The C2 ganglion lies in the C2 intervertebral foramen, dorsal to the C1, C2 facet joint, dorsal to the C2, C3 facet joint in the interdural space. Safe site for C2 screw insertion in the C2 pedicle is inferior and lateral quadrant, superior and medial quadrant, superior and lateral quadrant, inferior and medial quadrant.
Okay, keep going, Ahmad.
The direction of C2 screw insertion should be cranially and laterally, cranially and medially, caudally and medially, caudally and laterally. Wow. This you should have to know. Okay. What is the most frequent procedure in the anterior axis in C1, C2 fracture? A tensarticular screw, dense axis screw, dense axis resection, anterior decompression. What is the significant advantage of posterior C1, C2 fusion compared with anterior C1, C2 osteocentesis? Decompression is easy, simple, and safe. Distraction is possible. Osteosynthesis can be done based on anatomical landmarks, even without X-ray. All of the above. That's an easy question. How can you achieve an anterior fixation of C1, C2 if all ligaments are ruptured? By transarticular screws, by a single dense axis screw, by two dense axis screws, by wire fixation. What is the most frequently used procedure in C1, C2 instability for fixation? C1, C2 osteosynthesis according to Goel. C1, C2 fixation by wires. Huh?
I'm just asking not to move up.
C1, C2 fixation by wires, C1, C2 fixation via transarticular screws, C1, C2 anterior transarticular screw fixation. And the last one, I think, is it? In C1, C2 instability, due to tumor destruction of C1 lateral mass on one side, by which technique reaches the highest stability? C1, C2 osteosynthesis according to Goel. Now I cannot read the remnants. Well, the last question was difficult, but I think all of the above.
Good answers.
Okay. To Peev said. Okay. It's Atul's question, but I think the most difficult part is the inferior, the pars. But anyway, I don't know. The vertebral artery has a close relation with what portion of C2? What is your answer, Sama? If Atul, there you are.
Yeah.
We were missing you for your answers.
I think this is not a wrong answer. The superior facet is a good answer. Actually, pars is a very small pars. You know, the definition of pars is quite a controversial. What is this pars? Actually, is a difficult anatomical area. It's a very thin area between the lamina and the pedicle, posterior. And this pars is quite posterior. So I think superior facet is a good answer.
Do we accept pars or not?
No, superior facet.
Okay. Then your next question. The C2 ganglion lies dorsal to the C1, C2 facet joint.
Yeah, that is, many people have written it beautifully. I think that is a correct answer. And this, many people have responded correctly to this question.
How comes that we have almost 300 participants and only 50 answers? Saman, what is going on? What shall we do? Make your choice. I will not look up your names. Okay, go to the next. Safe site for C2 screw insertion is C2 in C2 pedicle is superior and medial quadrant. Atul, is also your question.
Yes, this is correct. But I am surprised that many people have written inferior and middle quadrant. That is a, maybe very, very dangerous to put the screw. Maybe they have not exactly this quadrant thing. They have not exactly understood what quadrants were discussed. But I'm not.
The more caudal you come, the more dangerous it is, right?
More caudal and more lateral.
The medial is really not an option. The inferior is really not an option.
Yeah, inferior and lateral, both are dangerous. So superior and medial. So these are the quadrants which are the best.
Next one, Imad. The direction of C2 screw insertion should be cranially and medially.
That's correct. That many people have answered. And I think that is a beautiful, correct. On the other hand, direction of C1 screw. You see this C1, many people have written cranially and laterally. I think this may be okay for C1, but for C2, cranially and medially is the right answer.
Good. What is the most frequent procedure in an anterior axis in C1, C2 fracture? Dense axis screw. I think this is correct. Transarticular screw is very rare. I tried to point this out. Maybe I didn't make myself clear. What is the significant advantage of posterior C1, C2 fusion compared with anterior C1, C2 osteocentesis? All of the above, correct. Oh, good, almost 70%. Thank you. Next one. How can you achieve an anterior fixation of C1, C2 if all ligaments are ruptures? By transarticular screws, correct. Well, actually, I think it's a very, very rare indication, as I pointed out. What is the most frequently used procedure in C1, C2 instability for fixation? Imad, a little bit up. C1, C2 osteocentesis according to Goel. Yes, I think it's correct. Next one. In
Just
C1,
I will like to make a smallish comment here. I completely agree that this is a beautiful technique, but you know, this technique involves not only screw fixation, opening of the joint is important. Removal of the articular cartilage is important. Introduction of bone graft within the joint are additional things that we must not forget. And these things are possible only if you use this technique. You see, if you use transarticular, you cannot open, you don't open the joint. You don't distract the joint. You don't manipulate the joint. There are so many things you can use by manipulation of joint, by handling the joint, by distraction of the joint. So these things are possible only if you use this technique. If you use any other technique, these things are not possible. Like for basilar invagination, if you are going to treat basilar invagination and instability, you have to open the joint, distract the facet. If you are not doing, then you are doing incomplete stabilization.
Well, I think this is a big advantage compared to the anterior approach. I mean, if you could deal with a joint from anterior, maybe the anterior would be more interesting. But since you have no idea what to do with a joint, you just screw the cartilage together. It's not an option, in my opinion. So the next one, what is this? In C1, C2 instability due to tumor destruction of C1 lateral mass on one side, which technique gives the highest stability? Well, there I would not agree. I think on the cadaver studies, at least the transarticular screw on one side gives more stability than the lateral mass screw on one side. So I think the right answer is C1, C2 fixation via transarticular screw. But obviously this is controversial and I'm sure Atul will not agree with me. So I think we move on to the next one. We have only 1 minute. 1 minute left. What is next? We have more questions or not? No, sir, I don't see the Imad, where are we?
Yes,
we're done?
We are done.
Okay, so we see a result of the quiz or nothing?
Ahmad, do we have a result?
No, sir.
Okay. So can we unshare the screen and can you show us the poster for the neuroanatomy course, the whole neuroanatomy course of what is coming up next? So this is Pearls from the OR. That is actually on 26 and 27 June. And this time it's on deformity. And this, again, a 2-day course, just like the last time. And it's only for the members of World Spinal Column Society. And you see, there are ways of becoming a member, which I'm sure you can access via the website, as well as it's written here in worldspinalcolumn.org. And we have some brilliant speakers here, and we'll have a lot of fun. Can you also share the poster for the neuroanatomy course, the main poster? So our next is going to be on next neuroanatomy course will be on cervical spine in 2 weeks. Can you show us, Ahmad, please?
Yes, sir. I will not.
So basically, we would have, I think in that we have Mehmet Zalili from WFN Spine Committee. who's also a co-helper in this, co-organizer in this. And along with that, I think it's Sandeep Vaishya. Sandeep is actually, he's listening to us, but unfortunately he has COVID along with his son, and he's isolating at home, quarantined in Delhi. He's actually getting better, just has a lot of cough. Hopefully he can speak in 2 weeks' time. So our next session is going to be cervical. This is on 16th of May, same time. We'll try to keep it in time the next time. We just ran a little over time. We have brilliant speakers coming up again. And I thank Atul and Joachim and Ruli. Ruli, you want to say a few words, please?
No, nothing from me, sir. It's fine.
Atul?
No, I really enjoyed this program.
Yeah.
You see, there were 300 participants, and my feeling is even if 3 or 4 or 5 people can get thoroughly interested in this and take up this, it will be the success of the purpose of the meeting is served. And I have a feeling, as I mentioned, atlantoaxial instability is the most under-recognized and under-treated clinical entity. So we must not take this lightly. We have to learn and we have to do. When we take up our subject, we have learned, we have taken up because we want complex things to do. We want to do the most difficult things. We have to accept challenges, and we have come here not to accept defeat, but to conquer these defeats. So I encourage all of you, not 1 or 2 or 3, all the 300 participants to learn this better and to do it perfectly, because it is an absolutely necessary result-oriented operation. So that is my comment, Salman.
Brilliant. I'm grateful. I'm sorry there were a couple of people who wanted to ask questions and we couldn't allow because of the shortage of time. I apologize for that. You could email to us and we can forward it to the person that you're addressing, and we will get an answer for you. Don't worry. And next time, maybe in 2 weeks' time, hopefully we'll have more time so you can ask that question if you like. I apologize. Joachim, you'd like to say something?
Well, I think it was a very good webinar, and I think really that the topic was well selected, because regardless of what you do, if you do a brain surgeon, if you are a spine surgeon, if you are a neurosurgeon, whatever you address to, I think the craniovertebral junction is really the most difficult area to, judge the situation, make a treatment plan, and then perform the surgery. Everything itself is very challenging. So I think it was a good day. Thank you for all the discussion.
Brilliant. Can we have everybody switch on their video? We'll just take a quick picture and then we are off because we're running very late. Please switch on your videos if you can. I'd be grateful. Thank you. Thank you. I know Nikolay has got a meeting with somebody, so he had to go disappear. All the help. I'm thankful to the WFNS Spine Committee, especially Mehmet Zalili and Maurizio, who are my co-chairs, for helping. And everybody can smile. Don't need to be that serious, Atul.
No, I'm here.
Oh.
I'm here for the picture.
Oh, Nikolay is back for the picture. Where are you, Nikolay?
Taking his Jaguar. Good. Imad, did we do the picture?
Imad, picture is done?
Yes, it is done.
Done. Okay.
All right, brilliant. Thank you,
All the
Victor.
best, huh?
Thank you, everybody. And thank you for joining us, and hope to see you in 2 weeks' time.
Thank you, Salman. Bye-bye,
Bye-bye.
Atul.